Senior Manager of Patient Programs here at Global Genes, and I run a lot of our programs that are connected with health equity, diversity, and inclusion. These series of 3 webinars are part of that. Get started. So this first webinar, we are calling it Defining Your Underserved or Underrepresented Patient Population. So in this discussion, we're really going to talk about kind of the areas of need for diversity, equity, and inclusion in patient advocacy organizations. It will be a discussion of how to look at the patient population that you serve and identify gaps, as well as kind of what are the first steps to figure out who is not being currently served or represented by your organization and would benefit from your service. And that can cover a variety of populations, whether it be based on race, ethnicity, age, gender identity, religion, socioeconomic status, geographic location, linguistic barriers, or other. So with that being said, I'd like to introduce our 3 incredible panelists. First up is Khaleelah Cohen. She is the Diversity and Inclusion Programs Consultant from Foundation for Sarcoidosis Research. Khaleelah has over 12 years of nonprofit sector experience. She currently serves as Diversity and Inclusion Program Consultant for the Foundation for Sarcoidosis Research, where she leads diversity programming, including the Ignore No More African American Women and Sarcoidosis National Awareness Campaign. In previous roles, she oversaw the enhancement and execution of numerous program initiatives, campaigns, and national training conferences for national and international nonprofit health organizations. Khaleelah is a California native currently residing in Washington, D.C. Next up, we have Lisa Schoyer, who is the mom of Quinn Johnson, who had Costello syndrome and died in 2002 at 6.5 years old of embryonal, oh man, I'm gonna mess this up, Lisa, embryonal rhabdomyosarcoma. Hopefully that's close. Related to the syndrome. She's a founder and president of the Rasopathies Network USA, which was incorporated in 2010. Lisa also is a trustee of the International Costello Syndrome Support Group, as well as the past president and past secretary for the American Costello Syndrome Family Network. Among her achievements, Lisa has partnered with researchers and clinicians to provide biennial NIH-funded international scientific symposia involving families, clinicians, and researchers starting in 2007, of which all but the 2011 symposium were followed by a publication on the meeting's proceedings. Though trained as a professional of studio art, after Quinn died, she was hired by the County of Los Angeles, first as Chief of Family Support at the Los Angeles County Department of Public Health's Program for Children with Special Needs, and since then for the county's Department of Mental Health and the Prevention Bureau's Family and Community Partnerships Unit, where her passion is helping mental health clinicians provide appropriate mental health services for those with IDD, where she continues her exploration of health and mental health equity. And last but certainly not least, we have Tuesdi. Dyer is a certified fundraising executive and executive director of CFC International, a global medical research and treatment foundation dedicated to the support of patients impacted by CFC syndrome. This is also the rare disease her 8-year-old son was diagnosed with at just 4 months old. As a result, she has been a leadership council member of the Global Genes Foundation Alliance, a member of the Johns Hopkins All Children's Hospital Advisory Board, and currently serves as vice chair of the Rare Epilepsy Network. Tuesdi has worked as a director in nonprofits for 20 years and has served on multiple community nonprofit boards, which include serving as president of the Junior League of St. Petersburg. Through her work with the Nonprofit Leadership Center, she has consulted with and coached nonprofits, training them on fundraising, board governance, volunteer management, and business planning for social enterprise. Tuesdi lives in Austin, Texas with her husband, Brent, and sons, Ellis and Emmett. She holds a BA in political science from Texas A&M University. We're very excited for all of our incredible panelists. And I just wanted to note too, Tuesdi and Khaleelah both received our Health Equity Impact Grants last year. I know there's a few folks on this call that are from our awardees for this year's Health Equity Impact Grant. And so Tuesdi and Khaleelah will also be able to talk a little bit about kind of how they approached that work when they were starting out. So with that being said, I'm going to ask kind of the first question, and anyone who wants to take it really to start us off is how do you define health equity, diversity, inclusion? What does that mean for you and in the work you do? Lisa's already unmuted, so I'm going to lob it over to her.
Well, heck specs, as it were. I think sometimes I just make this assumption. So I think this is a great moment for me to step and re-review. It's the representation of people of color and different socioeconomic statuses and cultures, because we really need to approach all types of people in order to make an appropriate and effective intervention for the syndrome that we're trying to find repair from. How's that for spread out definition?
Oh, I'm muted.
It's like, do I need to talk more?
No, sorry. Khaleelah, would you want to go next?
Sure. So, yeah, I mean, I think it's a tough question because it's become something that we use for so much. But I think, you know, like its most general form, it's ensuring that there's meaningful representation of historically marginalized and underserved groups, ensuring that their experiences and circumstances are incorporated and considered throughout in organizations, so like internally, but also like when you're looking at your patient programming, if your community is patients, but making sure that you're distributing your resources, you know, equitably, but that you're focusing on these groups that need more care and have a special certain set of circumstances that need more attention. So in our organization, we let the data inform that. And started with the most underserved group and what their barriers were and focused on moving forward from there.
Before I go to Tuesday, I wanted to follow up with you, Khaleelah. You said you let the data kind of inform that. Can you talk a little bit more about kind of where that data came from? How did you collect that information?
I should just stay unmuted, right? Sure. So so there's a lot of research out already over the last, I'd say 15 years, I think, remembering article publication dates that I've looked at, but there's been a lot of research on African Americans and sarcoidosis, specifically African American women, because their rates were so high. So they were 10 to 18 times more likely to be hospitalized than white men and women who have sarcoidosis. They were 12 times more likely to die. And so these are like staggering statistics. And we also have a board member who is an epidemiologist, and she published a lot of articles on this, and she has a Black Women's Health Study. So pulling from that data, looking at our patient community, which is, you know, we have a lot of African-American women in our community as well, which is representative. And so that was really our first step, is trying to understand why those statistics look like that, you know. And we know that there's three, we know it's race, gender, socioeconomic status. With our disease, sarcoidosis, there is a environmental and a genetic component. So trying to understand, are there genetic components that are making them more susceptible as well? So that's how we kind of came to that.
Yeah, awesome. Thank you for sharing.
Mm-hmm.
All right, Tuesday, that same question, how do you define health equity, diversity, and inclusion, and how did you approach that work?
So for us, this really is about taking a deep dive internally into our programs, and not only just our programs, but personally within each staff and board member and volunteer that we have, to really examine how barriers have been created for marginalized communities at every level. And when we aren't able to really examine those barriers properly, making sure that we have the right people at the table and we're listening and we're hearing what they say about those barriers to services, to diagnosis, to participation in the organization, to access to our events. For us, it really was about deciding that, or realizing that every single component of what you do, from the moment you wake up to the time you go to sleep, in your work, in your foundation, really has to be making sure that you have the diversity, equity, inclusion lens. And that if you cannot if you cannot have that lens yourself, I mean, and I speak for myself as a white woman, if you cannot have that lens yourself, making sure that you have the right people at the table and the right voices at your table to have that lens and to create those access to services for you.
Yeah, that's awesome. Thank you. And I know we've talked about this a little bit, but for some on this call, and for myself included, this work can feel very daunting, right? You can feel, especially as a white woman in the space, you can feel kind of like, ooh, maybe this is not my place. Maybe I don't know how to approach this. I want to approach it respectfully. I don't quite know how to do that. So what were some of the lessons you learned along the way, and how did you kind of go into it, recognizing that, and how did you address that? Maybe some of that discomfort, right?
So there was a significant level of discomfort for me because obviously not representing a marginalized community from any aspect, right? In the, from a disability community, from a sexual orientation community, from obviously, cultural and racial communities. So I would say the biggest thing that I realized first was, in my head, I had this work as a sort of tiered approach. So we make sure that we're following the best practices in our programs, and then we figure out how to pull diversity, equity, inclusion into them. And that is entirely wrong, in my opinion. You work in their best practices of your program, all the while making sure that you have diversity, equity, and inclusion in them as also a best practice. And so I would say in my brain, I thought, we're not ready to do this work because our programs are not, in my opinion, functioning as a best practice. But best practice is actually diversity, equity, and inclusion. And that was a real mind shift for me. And an important mind shift. And so I think the thing I would say is, if you're feeling a little bit like, where do I play a role in this? Am I the right voice at the table? I think that's what I kept saying to myself over and over again. Am I the right person to be doing this work? The answer is yes, you are. And the other answer is, the work it happens in a symbiotic relationship with all of your best practices for your organization. It's not a one and then the other.
Mm-hmm. Khaleelah, I see you nodding. Did you want to join in there?
No. She really laid that out, perfectly. And that's important. It's not, they're not siloed programs. It's not a second thought, like it's not a box you're checking off. It needs to really be intertwined in everything, in the fabric of your organization. And that's the lens that you should be looking at, because that's the more inclusive lens. And so when you build something first, it's not build and then they'll come. Who are you reaching? And you include them in the building so that they feel a part of it, and so that, it helps you avoid pitfalls, especially, I was going to say, especially if you don't represent the community, but I represent the Black community and I still don't, there's so much diversity among Black women, and I don't represent all of that. And I don't know, so even when I'm working with, I was leading a campaign for Black women, and they helped me avoid some pitfalls that I didn't see, so, no matter who you are, it is important to include others that represent that community, because it's not a monolithic group.
Yeah. Lisa, go for it.
I'm ready. So I just love everything both of you have said, because it is the ideal, and it is actually happening. And so that's really, I just love it. And the other piece that comes up for me is that sense of imposter syndrome, right? Even as we represent from others, potentially at least one population that what the general white population is looking for, we have also internally ourselves not the ability to represent all, I can't represent all Chinese. I just, I still remember a friend who said at a restaurant, she'd love to say, okay, I'll do all the ordering and everything. And and she said, okay, Lisa, what do you want? And I said, well, do they serve snails? And she said, Chinese don't eat snails. And it's like, this great friend of mine, she had been so used to being the Chinese person among people that she would always say, Chinese do this, and she'd give me a second bowl of rice. Chinese eat second rice, second bowls of rice. It's like, So until then, even, she was the one who helped me realize I myself, when I found myself in such situations, would do the same thing. So, pulling back, recognizing I cannot represent everybody of my whatever label, right? All women, all Chinese, everything. Or as Tuesdi clearly reminded, is I'm also cisgendered. So the piece then that comes back is something that I learned from my mental health, birth to 5 mental health, is repair. My first years in the department, I helped do trainings, set up the trainings, and in the background, everything was about how the mother was screwing up to make a baby that was either neglected or abused. It's like, then I looked at my own life and laid that guilt on myself. And then he came in and he said, that's the ideal. No one has that because no one knew about it until we started doing the research. And so the piece was recognizing that no matter what we try to do, we're going to make mistakes. We're going to make mistakes. And the piece then is when someone gives you the clue to, if we really are invested in this, we have to admit our mistake and then to work to repair it, because we have to learn from the people that we don't know very well how to best connect with them, how to build the trust with them, and then work from there. I'm so jealous in a way. I mean, I hate to say it, Khaleelah, but to have all that data is a huge step forward to know where to go. For us with rasopathies, I'm in Los Angeles. I should be able to find people, anybody, to join the Rasopathies Network, and or at least any of the family organizations that we work with. And they're not interested because we haven't reached that level of relevance for them. So that's another piece that I'm working on.
Can you expand on that a little bit more? What do you mean by that level of relevance, and who is them in this situation?
I think for me, especially in Los Angeles, it's people who aren't used to using the internet, because that's how we usually reach people across the world. And that right there talks about a class of privilege to have the education and the opportunity and interest in using the internet, for example. And that's the best and easiest way for us, with no money basically, and working as a volunteer organization. To that though, as I said first in the beginning, we really do need to reach those people, because if we're going to make relevant inroads for effective therapies for quality of life, we have to understand what quality of life really means first. So if they don't have the transportation, if they don't have an inroad into the health system because the doctor minimizes the issues, right? I even remember one family from Northern California, from a very privileged county, I will admit, where she had private insurance, and somehow we reached each other. She had a child with Costello syndrome. I'm not quite sure how much involvement there was, but 95% of our children are very, very involved medically, and have G-tubes and all this other stuff. And she said, I said, trying to give her as much resources and information as possible. Well, do you have a connection with your Regional Center for Developmental Disabilities in your area? And she said, my pediatrician said that I'm not eligible because we have private insurance. And that's not true. This program is income blind. And so she had lost access to an entire bank of resources. I mean, that's one huge door that California provides. It's the only state in the union where the services are entitlements. And this doctor shut her off from that. And she's somebody who had privilege. She had private insurance. So I worry about doctors who don't know that and don't even know to not access services, and then from the services connect to eventually get to us in the rare disease, right? So to that piece, yeah. Just then they get used to, okay, I just have to deal with this, and I'm not gonna try.
Yeah, and so kind of given that we rely on clinicians a lot to identify, individuals, how do we surmount that challenge, that access to healthcare challenge? It's a challenge that's across the board, whether you have privilege, but especially if you don't. Do you have thoughts on that, Lisa?
Well, one is to find the finders, and so making networking work, particularly given how rare our diseases are, trying to reach out locally. And I've been doing that here in Los Angeles. We do have a standing meeting for a program for children with special healthcare needs. And another mom and I, or she's actually a grandmother, and I are quite frustrated that they're not doing more. So we're working on, okay, let's make a subcommittee. And her focus is sickle cell. And, there's a lot of information out there, but it's not being used. And that's really frustrating to her. And so I'm piggybacking and learning as much as I can from her, how they have gotten to that level, and then and we're both working on how to get to the doctors. I notice how Children's Tumor Foundation, which supports NF, neurofibromatosis type 1, manages with very small budget to engage doctors and clinicians across the country by incentivizing clinics with only $1,000 a year. And it's just like, how do they do that? So that's another question, especially I think focusing on hospitals that have training programs, right? Which I had listened to a book where it's like, the training hospitals are the worst place to go because you really are being used as a guinea pig. Who is it? Damn it. Gawande. So
well,
anyway.
While you're thinking of it,
Yeah,
finish your
go
thought.
Ahead. So there's a push-pull about going to learning hospitals because that's where you're going to get the young people, but you are also really a guinea pig for them. And that's also an opportunity, I think, to engage. Also to try to reach the public health medical system is the other piece that I'm trying to do with these networks.
Mm-hmm. Yeah, I mean, that seems like it ties well into one of the questions we got in the chat. So I wanted to give this one to Tuesdi. So Kate asked, underserved and underrepresented for us is often genetically undiagnosed. How have people reached countries and communities in regions of the world where medical advancement is a factor in identifying new patients for us to reach? Have you had success stories or medical or institution collaboration to increase awareness globally?
So I love this question because I think when CFC International started doing this work, immediately my brain went to this sort of global aspect and how we were impacting families globally. We do online support groups, and again, access to the internet is not an assumed. We can't assume that families have access to the internet, but on our support groups that we do 2 times a month, we have families who call in from Pakistan and, all sorts of places around the world. But when we talk about even more marginalized places of the world, we're talking about places where there may not even be access to clean water, and there may not be, there may be even more deficits to diagnosis or barriers to diagnosis. And so, of course, my brain went to this place where I said, oh gosh, okay, we have to get the UN involved, and we have to go and we have to ask, we have to get information out about CFC syndrome. And The thing is, it's like that elephant, right? And you cannot eat it at one time, right? You have to take the bite and you have to figure out where the bite is, the first bite should be. And so for us, when we started taking a step back, we started to realize that one of the big barriers to access that we could start working to overcome was just simply the fact that if you're going to be diagnosed with CFC syndrome, you'll get a facial phenotype sheet. And that facial phenotype is for a white, Eastern European, Anglo looking child. It doesn't represent any other ethnic population. And so if you're being diagnosed, for example, in Malaysia, and your child has CFC syndrome and the doctor's looking at this facial phenotype, your child is likely not going to look like that picture at all that was created of a child with CFC syndrome. So we just started, and I will say, I would love to share a success story and say, this work is all done, right? But even though it's a small bite of the work, it's a very long bite of the work, which is that we really have to start engaging, and we've begun to work in engaging clinicians from around the world who can help us create simply better facial phenotypes for individuals with CFC syndrome.
Yeah, and that reminds me of something that Khaleelah talked about actually when we were preparing for this webinar, where you mentioned that it's not I'm just trying to find the exact thing that you said here. It's not a short-term fix, right? It's about the long-term investment. And so I wondered if you can touch a little bit on that. Khaleelah.
Oh, me, sorry.
Yeah.
Goodness, what's it about? Okay, we talked about so much, right?
Yeah.
So yeah, it's definitely a long-term investment. I think one of the examples that Tuesdi had brought up was just looking up superheroes on Canva. And so she types in superheroes and she wants diversity. And so her mind is that I'm going to get all the superheroes. And they were all Caucasian superheroes. She couldn't find any superheroes of color. And for me, like I immediately was like, we have to type in black, or you have to type in brown or whatever. Like I'm used to that. That's like a given for me. I have to say, black hair, like what are the cool hairstyles this summer? Black hair, black model, black whatever. So it's something that, I'm used to, to doing that maybe someone else would take for granted that this would just pop up. But again, just with her example of having the graphics or the images of certain diseases and making sure that that's incorporated, it really just underscores her earlier point where you can't build it first and then think diversity later. So when they were gathering all of these photos, the first thought should have been, this looks different on different people. So let's start this now, instead of many years later identifying a problem with it and having to go back. But again, like she said, with the long bite, it is a long-term investment. It's many communities, and I'll go back just because of my focus looking at like racial equity. Many communities are used to organizations coming in and then leaving. And what you don't want to do is to just look at it as a siloed program, or even this campaign is not, it had a start and end, but we're on phase 2 now. And we're, making sure that every webinar we're doing, if we have clinical conferences with physicians, we're going to talk about these disparities that exist and what their role is and what they can do. So making sure that that is incorporated in everything that you do. And so that's what I mean by it's a long-term commitment and investment. And these communities have a distrust sometimes because organizations come in, make promises, get the data, and they're like, oh, good. And then they report to whomever and say, oh, this is the impact we had, and they move on. And so it's important that you build a lasting relationship, one that's reciprocal. I talked earlier about making sure that you're incorporating this community in your planning early on, but you also are going to have to get buy-in from the general community, even when you have that committee. So for us, it worked with partnerships, and I think that's best practices, period, just really using people that are that have established trust in the community already and going to them and including them in what you're doing. And you may have to, in some cases, prove yourself because again, they're used to this happening. So I think, did that answer?
Yeah, and it
Okay.
really, I'm gonna kind of put a pin in that, and I want to come back because there's a question in the chat that really linked into kind of working with those community partners. Before we get into that, I wanted to just go back to Tuesday really quick. I know a lot of folks are on this call saying, hey, we want to just know, like, we don't even know where to begin. We want to know how do we identify who it is that we're not reaching? I mean, we know who we are reaching. I know, Khaleelah, there was a ton of research that you guys did. There was papers published it was almost, it might've been a little bit easier because you kind of had all that data that you could say like, oh yeah, look, this is clearly the community that we need to reach. For Tuesday, how did you kind of go about that with the grant project that you did last year? How did you initially start saying, like, identifying who it was that you wanted to reach? And then, you know, I know you kind of did a little bit of work with having focus groups and listening to what the community needed and stuff. So if you could talk a little bit about that, that'd be great.
Absolutely. So initially, like, I love that Khaleelah talked about really getting buy-in and trust from the community, because that was also something that I had not paid enough attention to. And so I went in, you know, with just super optimism and just said, you know, this is so great. Our families are really going to want to engage in these conversations. And about 2 weeks into this work, I realized that's not true at all. I mean, our families are very busy. They have a lot of things going on. And just because we're now talking about diversity and equity and inclusion, and we haven't before, doesn't mean that they all of a sudden want to be a part of those conversations. So I really had to get to a place where I frankly had to call families and spend a lot of time on the phone with them, garnering trust in what we were wanting to do. And sometimes just talking to them for 2 hours about you know, the problems that they're having with disability services in their state, and not talking about diversity, equity, and inclusion. And it made me realize that I hadn't put enough work into really making sure I was accessing our families in a way that was really broad and diverse. But also it made me realize, like, this work is, you know, it's not, just because we do it doesn't mean everybody's going to want to be a part of it. And if we, and that really comes from the fact that people are busy. People want to make sure that you're doing this, and it's not just a one and done. And that when the grant is over, it's not about meeting a metric and then you move on about your business. And it's really about engaging people in long-term conversations and coming up with positive solutions to problems. And so we, you know, I called and talked to families, and I knew that, you know, I talked to our families in the Black community, and I talked to our families in the Latinx community, and I really made sure that they understood what we wanted to do. And those were phone conversations. Those were not broad emails. Those were not social media posts. Those were not just these general sort of cast a wide net and see what happens. They were really intense conversations. And I would say also, you know, in kind of closing that out, we didn't get a lot of buy-in early on, and it was a struggle. And we had to listen, and maybe we had to listen to 1 or 2 families, and then we got maybe 3 or more families that got engaged. And, you know, and knowing what partnerships and communities you need to go to, because I saw that was a question in the chat. Ask the community. Don't decide for yourself. Don't decide that you need to really be engaged in, you know, churches. Ask the community and find out where they want you to be engaged. And so I think that was a real learning piece for me too. I mean, I feel like—
did you, similar to Khaleelah, have a bunch of data that you were able to rely on to say, like, hey, okay, this is how we're going to define who is the underrepresented within our patient population? Or were you more just like, I don't even know where to start, and I'm just going to start talking to people and like have focus groups and see where the need is?
So we did really focus on Black, Latinx, and Asian Pacific Islander families, right? And so because we also felt like we couldn't do it all at one time. But then
I guess,
oh,
sorry, I just really want to interrupt really quick. Why is it that you focus on that group?
so we really, so initially what we were hearing in conversations before we started doing this work is that there were barriers to diagnosis. And actually, I will say, one of the first things that came up for us was just this anecdotal information from families here in the United States who said, I didn't get a diagnosis because I didn't look like the facial phenotype. And that's where it was kind of like a, whoa, we have all this anecdotal knowledge that families aren't getting access. I mean, obviously, there's really great diagnostic programs throughout each state now where people have access to diagnosis earlier, potentially even in pregnancy or earlier in the child's life. And that's great. And, you know, insurance is better about covering those, and so is Medicaid. But what we didn't have was like that little piece in between that was like, okay, this is so great that you have more access to genetic diagnosis, but there's still people not getting diagnosed. And what is that? And then the more we started to ask our families, the more our families would say, well, I mean, my child is Black, and the phenotype for CFC syndrome is curly hair. So, I mean, that was really, and it was one mother who said that to me about her daughter who didn't get diagnosed until she was 10 years old, which is just astounding to me and just almost unheard of now for us. And she said, well, I mean, my daughter doesn't look like someone with CFC syndrome. But that, and when I said to her, you know, I think like, the more we talked, you know, I think she said, well, actually, she does look like somebody with CFC syndrome in the Black community.
All right, I think we have time for one more, and then we'll open it up to questions from participants. So I'm going to ask this one to Lisa, and it's actually going to come from the chat. How do you engage in kind of tying up with what Khaleelah and Tuesdi have been talking about, right? So how do you engage those community partners, such as religious organizations, social religious, different organizations, and how do you work with them to say like, hey, we have this benefit that we think might be a benefit to you. We have this resource that might be a benefit to you, but they're not super interested.
Boy, this is exactly the gap that I'm working on. I think the piece is what helps me actually is finding this article that was just published by NASM, the National, what's it called? Go to the top of the article. The National Academy of Sciences in Engineering, Science, and Medicine. And what was really eye-opening to me, this is a 400-page document, and so I scrolled over to the chapter that I found interesting about approaching people, underrepresented people for clinical trials, is they're interested, right? So my perception that, you know, they don't have an interest because they're not engaging even into the medical system and everything, it's just like, granted, this is about cancer research. That's what they used as a model. But to stop myself from thinking that it's hard, I think that's the hardest thing, right? That first step to say, actually, there is engagement available. I just have to get there. And so then what's the next step? So the next step is, I think, networking, saying we're out here. If you know anybody, and in the meantime, you know, here's how I can help with those resources. Getting back to, you know, when Tuesdi was saying that the issue isn't the disparity and equity, the issue is not getting services. But the fact is that when those people say that, they are actually those who are affected by not getting services because of their lack of access due to their income and or color of skin. So that's the piece where even helping them understand that's been something that we've also seen in the rasopathies is getting the parents to understand where they're standing, to help them define that. And that's not simple to say, hey, that's because you've been discriminated against. You don't quite want to say it that way, like, and then without a lot of repair, right? So I think it's to be careful to listen and help people help us help other people is going to be the way to do it. And it's not short, as everyone has said, Tuesdi and Khaleelah. It really is finding those community partners and working with them, getting their trust, because they're busy as heck too. And I can say that myself. It's like there are so many great national organizations that I should be participating in, and there's only so much bandwidth. And that's what I was trying to get back to with people who have been marginalized, is they've been so marginalized so long, the relevance to their daily life isn't, for us to come in, isn't there. So then we have to think back, what is our relevance? And how can we package it in a way that makes sense to them to engage? So,
Yeah.
It goes back and forth. and don't stop just because we haven't gotten it. I think all of us here, what's really cool is it hasn't stopped us to get where we are now. So
Yeah.
Just keep on moving.
Keep on trying. Well, thank you all. Oh, go for it, Khaleelah.
No, I was just going to say there was a point that I think is important that I forgot to share, just in terms of just following up on everything. When you're looking at building trust in the community and partnering and all of that, you must look within your organization. That is really the first step, because your leadership, who represents and has a voice in your organization matters, and you should have representation from that community in leadership positions. And so that is definitely something that people look at. Other organizations and community members. If your board is, I always use this example, after George Floyd, like Black Lives Matter, like we had Netflix, MedStar Health, companies you wouldn't even think get involved, publicly, saying Black Lives Matter and sending out stuff and putting things on their website. And that is a great public declaration of support. But when you go to the website, it's like white male, white male, white male, white male. And so it looks like, okay, well, is this really an investment? Are they really committed to this? And listen, you can wake up at any time and not flip your board, or, things don't change overnight. And so don't be discouraged by that, but it definitely should be something that you are identifying as a blind spot, and something that you're working towards while you're doing all of this work. But you definitely should look at making sure that you're diversifying leadership, and not just, allowing people to sit at the table, but like eat at the table, speak at the table, all of that. And so it's really important that those positions are held.
Yeah. Well, thank you all so much for sharing. I am going to open it up to questions in just a minute. But I just wanted to thank you so much for sharing your insights. And I think that kind of in a summary, approaching this work can be tough. It can be daunting. It can be really scary, and it can be uncomfortable, but you have to kind of sit in that discomfort, and just being open-minded and being kind of a kind, genuine person who approaches this in a way where you're like looking to learn. We are all learning together, right? And so with that in mind, one thing that I've talked about with some other folks, I don't think we've talked about it with you guys, but like the reason we at Global Genes, we kind of say equity, diversity, and inclusion, as opposed to most people put diversity first, is because just because you have quote unquote diversity, you might check a box, right? You have pictures of different people and different skin colors with different disabilities and various genders on your website. Great. Okay. Looks optics wise like you're a diverse organization, even if you have those people in places of leadership. That doesn't necessarily equate to equity and inclusion. So that's why we kind of put those first, right? You first have to have that equity, that you are providing services to people, reaching them and meeting them where they're at, regardless of who they are. That will kind of lend itself into having more diversity. So with that said, I see that there's one question in the chat. We'll start with that one, and then feel free to kind of raise your hand. Anyone who wants to ask a question, you can ask to a direct one of the panelists. You can ask to all the panelists, whoever wants to take it. So the first question from Melissa is, Are there any methods you've utilized, and this can go to anybody? It just jumped. Are there any methods that you've utilized besides direct hospital outreach and having internet media presence to access and find underserved or underrepresented populations? If these are the populations aren't accessing diagnosis and do not utilize the internet, how do we reach them? Whoever wants it can unmute and take it.
That's a tough one. I mean,
We're starting easy.
right. I'm just like, I'm going to go ahead and speak first, even though I don't have much to say. So the internet, like, this is very difficult because internet access is more widespread than we think, but on mobile devices. However, you know, it's tough with the pandemic because, you know, during that time, so much did change to switch over to virtual and relying on web-based information and outreach tactics. Prior to that, and now returning, I would say, you know, going to the community, what are existing health fairs in the community, a lot of, depending on what community you're trying to reach, going where they are. And of course, bandwidth is an issue here. So that's a difficult question. Partnering with an organization that represents a lot of organizations. So there's like coalitions. I think those are good because it allows you to get the information to them and they can funnel it down and they have the manpower and are already in the community. So I think it just really depends on who you're trying to reach, but those are just some of the ways that you can do that.
Yeah, and I see Cynthia Ryan posted in the chat that they use radio PSAs, which reach a different population, which is a helpful hint. She also asked a question, which I know, Khaleelah, you had kind of talked about this a little bit, but I'm happy for anyone to answer it. When we announced our DEI policy, we received some negative comments. You know, you're woke now, huh? How do you counter that, or do you just ignore that?
Does anyone else?
I would
Everyone answer.
Do you want me to say the truth, or do you want me to? Yeah.
I would engage that person. That is a good person to grab, actually.
So Lisa, you want to kind of elaborate on that? What do you mean by engage them and how?
Well, they've already indicated they're engaged. They want to see you, you know, they want to hold you to the ground, right? You're just lip service. Well, it's like, okay, I'm lip service. This is that trying to repair and trying to get, and that person has already, you know, it's that always I've learned, if you're the person in the room who has, you know, points to the problem, guess who comes to you to fix the problem? So that person is an ideal person to actually to reach out and say, thank you, right? And how would you help us not be that way? I mean, I'm looking for something like that, right? I mean, that really is the first step, and that's, you have to go somewhere, and to get that response is a good one.
So can I add something real quick, because I'm looking at this from the other lens, because this is where we got some feedback in our community and comments about being woke, which is, you know, my initial reaction is to just, you know, not be very nice about that comment, because for us, it was coming from people who were white, who were privileged communities, right? And I would say that very quickly, I identified someone on our board of directors who really understood what we were trying to do, but also represented a privileged community and had some respect in that community of being the voice to them, of saying, this is why we do this, and this is why it's important. And it's not about being woke, it's about including everyone. And because our feedback, we had some pretty interesting feedback from donors, which was really alarming to us. And we saw some, quite frankly, some eye rolls. And you know, that was very upsetting, because for me, I find sometimes personally, it's very hard for me to continue a relationship with people who don't see this as necessary, or who call us woke, or who roll their eyes when we talk about diversity, equity, inclusion. So I had to get past that part of me. But I had to also find somebody who was the right voice into that community that was rolling their eyes. And I know it also wasn't me, because in my organization, I am seen as the type of person that would do this work. And that does alienate some people who feel very politically different from me.
Yeah, so do I have time to?
Yeah, go for it.
Okay, so I read that, I thought that was coming from the community, that they were like, oh, you're finally doing this, which was funny to me. But so I would definitely, we received a lot of negative feedback, for one. And so I had to kind of take my personal hat off and really take a step back. So I listened. I recognized that there were biases going on, and the way you address that is through education and understanding that that's all you can do. So we're not funded. Global Genes didn't fund this for me to spend time talking to you about this and trying to convince you. Like, my goal was to reach the community that I need to reach so that they know about this disease. So, you know, we assessed our messaging to make sure they understood that helping those that experience the worst outcomes helps everyone. And we decided to do a pre-launch. So before our launch, we decided to spend that month educating people on health disparities and how social factors impact health outcomes. It's not just the color of the skin and then, oh, why does that matter? No, it's what comes with that. And that included a website, an infographic. We did a webinar. I called it our Trojan horse. The other thing is, and I'm talking fast, but do not label it, you know, like African-American women, blah, blah, blah webinar, because you're going to be preaching to the choir. For this particular purpose, you're going to be preaching to the choir. So we labeled it universal barriers experienced by, you know, sarcoidosis patients, because we wanted to get them all in the door and then lock it and teach them. So, you know, so they came in and we walked them through an exercise. You start off with 14 points, optimal health, optimal healthcare. Are you a woman? You lose a point. And so that's like, okay, white women are like, can see, oh, wow, I have worse outcomes than white men. Okay, do you rely on public transportation? You lose a point. Are you this? Are you that? And so what you ended up with is everyone was able to see that, okay, I do experience challenges, and I am, you know, I experience some disparities, but not as much as this person, because they also do this. So it allows them to see where their privilege is, because a lot of this comes from, especially in the rare disease community, feeling like we don't get enough attention, and now you're spending time on this, and I have it hard. It's not to say you don't have it hard, but you don't have it hard in the ways that these people do on top of it, you know? So that's pretty much what we ended up doing. And we did also enlist one of our white male sarcoidosis patients to write a blog so that he could represent, you know, and speak to the community from that lens. And so that was helpful as well.
And I love all of your responses. And I do also really agree with what Lisa said, is that, you know, it's being called, you know, kind of called into that, I think is a really good way to approach it. And some people too might say, well, like, this has been happening for years and I think it's a really popular thing right now. It's become kind of the new kind of hot topic for everyone to kind of jump on the DEI, EDI bandwagon, right? And that's not to say that's a bad thing. And so they might say, oh, now all of a sudden, why now? Why are you doing this now? Well, you know, you're right. You are right. We should have been doing this before, and we weren't. And we're sorry when we weren't, but it's better late than never. So even if we're doing it now because we're part of the group think and we're jumping on the bandwagon, at least we're starting to do it. And I would love for you to help us think about the ways that we can do it better. My last kind of thought was, Khaleelah, related to that. I mean, we did an activity when I was in the Peace Corps in Mozambique where we had to do this. It was like a race, and there was a male line and a female line, and then you had to get down to a certain point with like a book and like come back, and everybody in the line had to like circle through to get to this, just like a one down and back, and then before, you know, whoever team finished first won. And the men just had like a book in their hand, and they just like walked down, gave the book to the next person, walked down, gave the book to the next person. The women had to put a bucket on their head, carry a mop, have their books, tie a baby around their back, walk down, come back, give the baby the book and the bucket on their head and the mop to the next girl. Obviously the women lost, right? Because it wasn't that, you know, it was just an example of like, there are all these other factors that go into why young girls in Mozambique don't have as great of access to schooling, not because it's not available to them. It's not about them not having the school physical building to go to. It's about the fact that they have to clean the house and do all that stuff before they can get to everyone's question. Thank you so much to our incredible panelists for all of the wise words. And thank you to everyone for joining. Hopefully you learned something. Our next webinar will be on September 1st, 11:30 to 12:30, and it will be kind of the second in this series. So it'll talk a little bit more about what are some of the cultural nuances that you need to better understand to approach these communities. Before we get to the third one, which we'll talk and address more of that community outreach aspect. How do you partner with organizations? What are some of the marketing tactics you can use, that kind of stuff. So we'll hope to see you at the next two. The next one, September 1st, 11:30 to 12:30 Eastern time. Thank you again so much for joining us, and we'll talk soon.